Hello, this is Dr. Bernstein again with our July 2016 teleseminar. Thanks for listening. I want to give you my usual warning that I'm answering questions for a big audience, not for the individual questioner, simply because I cannot get a physical exam or a complete history, which all of these would certainly affect my answers. So my answers are going to be guesses, and the guess could be totally wrong for you as an individual, but of great interest for the population that's listening. We have a special subject tonight, which is how and why to use Tresiba insulin. Tresiba insulin is relatively new in the USA, has been used in Europe for a few years longer. It came to the USA about a year and a half ago, and I've been putting all of my type 1 diabetics on this insulin as a basal insulin for a very good reason. It lasts overnight. Contrary to what most doctors and endocrinologists think, the current long-acting insulins, Levemir and Lantus, unlike the original long-acting one, Ultralenti, they do not last overnight. They will last from morning until bedtime, maybe 18 hours, but because of the dawn phenomenon in the morning, where the liver clears away insulin at a ferocious rate, the blood level of Levemir and Lantus in the morning, let's say 8 hours after you inject, is too low to combat the dawn phenomenon. But the Tresiba seems to do the job. I said seems, it really does do the job. I've not found a patient where it did not work. So, and how do we use it? We give it on arising and at bedtime. People keep thinking you give the shots 12 hours apart. That is incorrect. We want the bedtime dose to be as close to the morning as possible for any long-acting insulin. And in this case, we give it on arising and at bedtime. Endocrinologists have been prescribing it once a day, which is incorrect, or they've been prescribing it every 12 hours, which likewise is not going to do the job. The once a day sometimes does the job just the way Levemir and Lantus do once a day. If you give an excessive dose, maybe twice what you need, that leaves a big bolus of insulin under your skin wherever you inject, and that slowly is released into the bloodstream because it's so big. Well, it's not slow, it's that there's so much of it that it lasts a long time. But the problem is, because you've been given so much, you're forced to eat to keep up with the insulin. And that's not the definition of basal insulin. Basal is to cover the fasting state when you're not eating. So if you give a large dose, you could make regular insulin last a week, and that's been done by John Galloway at Eli Lilly. He made it last a week by giving 70 units in one shot. Regular, which is supposedly a rapid-acting insulin. So giving excessive doses, more than you need, and injecting it once a day in one site ain't the answer. There are a few type 2 diabetics who may need basal insulin only once a day to cover the time when they're eating. That's another story. They're relatively few, but they do exist. I have people, type 2s, who perhaps cannot take glucophage, metformin, or some of the other oral agents like the Avandia or Actos, and we only have insulin to work with. And one shot of a small dose, maybe 1 or 2 or 3 units of Tresiba in the morning might take care of their daytime, but that shot is not basal. It's covering their eating. So that's a special situation. Anyway, there's one problem with getting Tresiba insulin, and that is getting your insurance company to pay for it. Some insurers automatically pay for it, and others will give you a tough time. It's quite expensive. My recollection is that one box of 5 cartridges totaling 1,500 units costs about $300, which is exorbitant. Eventually, I'm sure it'll come down as there's more competition. But there are ways of getting around the insurance company restrictions, but you do have to file an appeal, and your doctor has to fill out a form indicating that you've tried other insulins and that they gave you problems. That's basically the story with regard to Tresiba. We're now going to go on to the questions. And the first question is over here. I'm a 50-year-old female, type 1, 7 years ago. Well, that's sort of strange, but it can happen. I have followed your plan for years. You've saved my life. Current A1C is 4.8%, and I am very physically fit and work out 6 days a week. My doc ordered a lipid panel. Results are total cholesterol, 234, HDL, which is, according to the old standards, the Senator McGovern standard, that would be high, but we now know that total cholesterol has no cardiac risk associated with it, although there may be high risk for certain people at very low levels. Anyway, HDL is 94, which is protective. A high HDL is somewhat protective against heart disease. LDL is 132, which is a little above average for the general population, but again has been shown to have no relation to heart disease. Oxidized LDL may have a relation, and glycosylated LDL, which is not commercially available, has a strong relation with heart disease, and it's in the diabetics with high blood sugars that the LDL gets, glycosylated LDL becomes elevated. Triglycerides are 36. I might point out that triglycerides are currently considered a significant risk factor for heart disease, but this person's triglycerides are way below the average for the population. However, it must be pointed out that triglycerides vary greatly with blood sugar and with your last meal. So it's going to vary from day to day and maybe from hour to hour. So all of this, to me, looks like it wasn't even worth doing. That is, the lipid profile doesn't pay off in any respect, except to tell you that you have low triglycerides, which may be most of the time, but maybe not, and you have a nice high LDL, HDL, which might be of some value in preventing heart disease. The doctor ordered a statin because I am diabetic and total cholesterol was over 200. What do I do? Well, by now you can guess. The adverse effects from statins, the potential adverse effects, are considerable and have been underreported. I've seen adverse effects in about a third of the users that I've encountered. New people come in on statins, and new patients, and about a third of them are getting adverse effects, some of them disabling. So this is something that you save for a situation where it's a real must. And if you're interested in knowing what your cardiac risk is, the ideal thing is to get a combination of imaging studies, coronary artery calcium score, but then you have to, which measures the total amount of calcium deposits in your arteries. Trouble is that some of that calcium is in the muscle and maybe not doing any harm, and some of that calcium is lining the arteries, and if it is soft calcium or called fluffy calcium, it can break off and cause a heart attack further upstream. But if it's hard, dense calcium lining your coronary arteries, you're not at risk for a heart attack from that calcium. So in addition to a calcium score, you get a calcium density study to find out whether the calcium in your arteries is loose and fluffy or tight and hard. Yet there's still another study, which is a CT angiography, which takes a close look at the coronary arteries to see if any of them are nearly closed off. And that adds further information to evaluating risk. But looking at lipids has long ago been disproven. In fact, the lipid hypothesis was not based on any evidence, as you've been reading in the newspapers all over the world of late. So looking at lipids doesn't tell very much. If I want to look at something in the blood, I look at inflammatory markers and acute phase reactants like lipoprotein small a, which I found has a strong correlation if it's grossly elevated. Let's say the high end of normal is 75. I had a new patient came in shortly after having a heart attack, and her LP small a was 175. So LP small a, C-reactive protein, possibly tumor necrosis factor alpha. There's a long list if you're that concerned about this. Also serum beta-2 microglobulin. I've been testing most of these things for years. When I say years, I've been in practice over 30 years, I believe, and 33 years, and I've been testing all of these things for that length of time because they've been available. Not the TNF alpha, but LP small a and beta-2 microglobulin and so on. Okay, next question. My 17-year-old daughter was diagnosed with type 1 when she was 9. She has been having 3 weeks of continual lows at night with no insulin on board. I've had her off Lantus since Mother's Day. For some reason, glucose barely raises her, and she sometimes had to consume 200 plus carbs before her blood sugar rises, only to fall again 30 minutes later. Her endocrinologist did not know what is going on, and her thyroid levels that we tested were normal. Need your help. This sounds very strange. A type 1 diabetic who becomes not only cured of diabetes, but hyperglycemic. Now, years ago, before it was possible to measure C-peptide, there was a rule of thumb that doctors were supposed to use if someone is getting frequent hypoglycemia and they're not diabetic. And one was surreptitious use of insulin. This phenomenon was most common in nurses who could get hold of insulin and they'd give themselves injected insulin and then go to the doctors because they had hypoglycemia. So surreptitious use of insulin is probably the most common cause of mysterious hypoglycemia, and an insulinoma would be another cause. Insulinomas are tumors that produce insulin. They usually are not malignant, but they can give you hypoglycemia. And the presence of an insulinoma can be determined by measuring serum C-peptide level, because commercial insulin does not contain C-peptide. And if you're making a lot of insulin, your serum C-peptide is going to be high. I've explained in the past what C-peptide is. I even drew a diagram. It's manufactured at the same time as insulin is manufactured by the body. So a C-peptide test is justified. One other possibility, which I find hard to really consider, would be some kind of damage to the liver where it is not adequately clearing away insulin or raising blood sugar when blood sugar is low. If the liver is functioning normally, the half-life of insulin in the bloodstream is 6.5 minutes. So if you were to inject 10 units of regular insulin, say human insulin, directly into a vein, in 6.5 minutes, only 5 units are left in your bloodstream. In 13 minutes, only 2.5 units. In 5 half-lives, there's no detectable insulin left in your bloodstream. So the liver works very rapidly to get rid of any excess insulin in the bloodstream. So one could investigate liver function, but I'd first check C-peptide. Let me just see. Yes, then there's a question of why was the diabetes cured? Sometimes people with polycystic ovarian syndrome can have a cure that can spontaneously improve. Sometimes the medications used to treat PCOS can reverse the diabetes. It's hard for me to think of any other reason for the diabetes being cured. The first guess is always surreptitious use of insulin. Okay. Type 1 diabetic. Does Tresiba need to be given twice a day? Well, I answered that already. With the news coming from the American Diabetes Association about the SGLT2 drugs, not only reducing blood sugars, blood pressure, and weight, but also reducing the risk of heart attacks and sudden deaths by 38%. What is your opinion on this for your type 2 patients who are not at goal? I use the SGLT2 agonist as a last resort. Why are they losing weight? They're losing weight because they're losing fluid. They're peeing a lot. And if they drink adequate fluid, as you're supposed to when you take this class of drugs, you won't lose the weight, but you have to drink a hell of a lot of fluid not to lose that weight. And as far as blood pressure effect, because you're diuresing and losing fluid, you're reducing blood volume and lowering your blood pressure. So these are artificial effects from peeing a lot. This class of drug achieves its effect by causing you to pee away glucose when your blood sugar is lower than the usual renal threshold. So instead of peeing away glucose at a blood sugar of 165, you may be peeing away glucose at a blood sugar of 135. not really the way of doing the game that I would like, because there are side effects, namely dehydration. I've had patients with very high hematocrits, that is, their red cell concentration goes up and can increase the risk of clogging small blood vessels, causing a variety of vascular damages. I don't consider it a wholly safe product, and there are other oral agents that are much safer. But I have one patient who requires a lot of insulin. He has a number of problems, and says that the only time he gets normal blood sugars is when he's a type 2, is when he takes an SGLT2 agonist. And I prescribe it for him, and he's doing fine. But he knows he has to drink a lot of water. Okay, let's continue. I am currently on Lantus and Apidra and have unpredictable schedule. I was put on this insulin regimen. Furthermore, my doctor wasn't very approving of my suggestion of going low carbohydrate, as he said I was underweight. How would you suggest I go about the low carbohydrate diet? Well, the insulin that he's on has nothing to do with the diet. I don't like Lantus insulin. But to gain weight on a low carbohydrate diet, you need protein and insulin. And I've said this over and over on my Dr. Bernstein's Diabetes University videos, and also in my teleseminars. The way to gain weight on a low carbohydrate diet is to increase your protein intake and take additional insulin to cover the protein. Now, a crude rule of thumb that we point out in my book that you can use to start at guessing how much insulin to cover how much protein would be a half unit of regular for 1 ounce of protein, but then reduce it by, let's say, 25% to play it safe, because you might be taking too much insulin. That's a starting point, and then by trial and error you end up with the right amount of insulin for the right amount of protein. That's basically it. It's very simple. I do not have patients who fail to gain weight if we want them to. In fact, we had a boy come in, I guess, about 6 months ago, whose only problem was failure to gain weight. And when we looked at his diet, he was not getting enough protein. We gave him more protein, more insulin. Whammo. Now, let's see what we have here. Have you seen or heard of cases where metformin has caused kidney or liver damage? No, I have not seen nor heard of, but in theory, metformin is in the same class of drugs called biguanides as fenformin, which existed about 30 years ago, 40 years ago, maybe longer. Anyway, fenformin was associated with lactic acidosis in people who already were lactic acidosis prone. Who are those people? There are people who have damaged liver or damaged kidneys. So if you already have liver damage or kidney damage, you don't want to take fenformin. And if you want to play it real safe, you won't take metformin either. Now, that caution has generated a myth that maybe metformin has the capability of damaging kidneys or liver. That's not the problem. The problem is potential for lactic acidosis if liver or kidneys are already damaged, or if you're an alcoholic. and and those people are lactic acidosis prone. And lactic acidosis is not only very uncomfortable, but it can be fatal. I've lost 10 kilograms on a low-carb, high-fat diet, but weight loss has stopped since December. I have another 10 kilograms to lose. How can I do this while maintaining good blood sugars? Here, the game plan, first of all, if you're on a low-carb diet, you get it really down to a bare minimum, where the only carb you're eating is a few vegetables, as we indicate in my book, Diabetes Solution. Then you're going to have to start cutting protein. And I've done this with patients where we lower the protein and we lower the insulin. And insulin helps maintain fat stores, so that works. But before doing that, I would use agents that lower my insulin resistance so that I have to inject less insulin. Agents like glucophage, metformin, or Actos or Avandia, the thiazolidine diones. Now, I've indicated in the past that there are cautions you have to use when using thiazolidine diones. You have to check your legs for pretibial edema. If they're causing you to retain fluid, I would rather not use them. I gave a demo on Dr. Bernstein's Diabetes University where I show you how you check your legs for pretibial edema. Your doctor can do it. I would say if you're taking Avandia or Actos, you check maybe once a month and discontinue it if you're developing edema. It's not that the edema is going to kill you. It's that I've been burned by conditions associated with pretibial edema. I was the director of the peripheral vascular disease clinic of my medical school, and most of the patients in our clinic had chronic venous stasis ulcers. And before they ever developed an ulcer, they had pretibial edema. They had poor venous return in their legs for one reason or another, and you could see the healthy legs, but with edema, before they ever got the ulcers. So I was burned emotionally, and therefore I don't like pretibial edema. Let's see what else we got. So you take medications that lower insulin resistance. There's one other thing you can do. Building muscle mass lowers insulin resistance. So if you do muscle building exercise, you will need less injected insulin. It'll be harder to hold on to fat. Okay. Male type 1. If I eat, say, bacon and eggs with only 1 to 2 grams of carbs and 30 grams of protein, I notice my blood sugars rise very fast. Many state they need to wait an hour or so and then give a bolus for their protein. However, I need to bolus up front or else I spike. I'm just curious as to why this might be. Well, this is natural. This is part of the ball game. The people who have to bolus later are those with gastroparesis who are digesting too slowly. When I eat a meal, I have to take the amount of protein and the carbohydrate into consideration for my injection. And the timing has to be such, that is, how long before the meal do I inject, has to be such that I don't go up after the meal. And that requires trial and error. Now, one other thing that I do is I don't change the content of my meals from one day to the next. they stay the same for a year until I get bored with the meal. And then I change and I keep it for the next year. That way I always know how much insulin I need for a meal. That's basically it. You take your insulin ahead of the meal, but allow enough time to cover the protein. But if you have gastroparesis, all bets are off. You read the chapter in my book on gastroparesis, or you watch my videos on gastroparesis. I would like to know which exercise system is best for reducing stored muscular sugar. High repetition, low loading, or low repetition, maximum loading? This question is utter nonsense. There's no sugar stored in muscles. And what is stored is glycogen, which is a starch. And you want it stored in muscles because it could be a lifesaver if you develop hypoglycemia, or if you are starving, or if you stop eating for a day or so. So muscles store glycogen, and the liver also stores glycogen. I believe about 2/3 of the body's glycogen is stored in the liver and about 1/3 in the muscles. I imagine, however, if a person were very muscular, he might store more than 1/3 in his muscles, might store half or even 2/3. So you don't want to get rid of the glycogen in your muscles. You want to replace it by having normal blood sugars if you lose it. When do you lose it? Well, if you're running a marathon, you're going to lose it pretty rapidly. So you have to be drinking glucose drinks while you're running, etc. Type 1 for 25 years, 30 days on your program, going for a 5-kilometer run. What would you recommend to eat prior? Well, first of all, 5 kilometers is not that far. It's about 4 miles. I don't think it matters what you eat, but you do have to carry glucose with you, and you do have to check your blood sugar along the way. Now, even if you have a continuous blood sugar monitor, it's not going to do you much good because it won't pick up rapid drops in blood sugar fast enough. So you're going to probably have a friend every, let's say, mile and a half with a blood sugar meter to check your blood sugar, and you can take the right amount of glucose. Well, that may not be the right way because you don't want to be stopping and so on. So you do a sample run where you're not being competitive, but you're running just as fast, and you stop every mile, say, check your blood sugar, and you'll find out how rapidly your blood sugar's dropping, how often you have to drink glucose, how much you have to drink, and so on. So you carry with you, let's say, 2 bottles of liquid glucose. One is a backup for safety, and the other has just enough glucose in you to last you the run based upon your prior experiment. So you know that if you gradually are drinking that bottle over the course of the run, you'll end up pretty close. That's the best advice I can give. You can use that philosophy and come up with ideas of your own. Now, one little thing I can add, you asked what should I eat before. My guess is mainly protein, because protein is digested slowly and converted and can be converted to glucose as needed. I've heard some people say that they eat a lot of fat. I don't know whether that's wise or not. Eating a lot of carbohydrate is not going to do you any good. It's going to send your blood sugar sky high, impair your performance, make you want to pee, and that's certainly not the smart way to do it. You drink your glucose while you're running, not load up on carbohydrate in advance. Okay. Type 1 for 50 years, 50-year-old female. My endo insists I take simplest. Oh, this is the same question. She's asking, are statins safe? And we've been through this already. I would suggest that if she has evidence of high cardiac risk, that her free T3 be checked, because low T3 is a strong risk factor for coronary artery disease. I would also suggest that this lady have normal blood sugars if she doesn't want to have a heart attack. And that's about it. Let's see. I just want to cross this off because it's a duplicate. How do you better control your diabetes with having high cholesterol and high blood pressure? Is it all due to weight, or should I concentrate on just... Wait a second. Or should I concentrate on just being a vegetarian and losing weight? I am only 4. 4-year-old should get a lot of protein. They have to grow. They have to have normal blood sugars. And they certainly shouldn't be worrying about cholesterol, especially since even older people shouldn't be worrying about cholesterol. I have a feeling that this was a joke. If a parent is sending this in because they really do have a 4-year-old kid, they should read my book, Diabetes Solution, and all their questions will have been answered. If I choose to use alpha-lipoic acid supplements as an adjuvant besides strict low carb for my pre-diabetes, what is the recommended dosage? How often should I use it? And should the R-lipoic acid, should it be R-lipoic acid or sustained release lipoic acid? Well, first of all, I don't know how much value alpha-lipoic acid is. I don't have first-hand evidence. I had one patient who raved about it to cure his gastroparesis. You could look on the internet. There is a doctor who prescribes alpha-lipoic acid. Always use the R enantiomer. The R is the active one. There's a doctor who uses alpha-lipoic acid plus low-dose naltrexone to treat a variety of cancers and claims amazing results. His doses are very, very high. I don't recall whether he gives it intravenously, but he might. And I don't recall what he calls low-dose naltrexone. But that's for cancer. So what you want to do with alpha-lipoic acid is up to you. Use the R enantiomer, but also use biotin. Alpha-lipoic acid depletes the body's biotin stores, so it can be harmful. Therefore, you need it with a biotin supplement. And there is a product called Insulo, INSULOW, that contains the right amount of biotin for a given amount of alpha-lipoic acid. And it's not inexpensive. The manufacturer, I believe, is in Florida. You could find it on the internet. I even think that Amazon may sell it. Type 1 for 19 to 38. It's hard my guess is that this is a type 1 since he's 19 and he's now 31 years old. Since getting a freestyle meter, my profile is in line with your book, with my night lantus lasting 6 to 8 hours, like I told you guys earlier. Daytime fasting, no snacks, it seems to last 9 hours. I use Humalog for meals. Should I use fast-acting until bedtime some 8 hours away? Well, this person is saying that his lantus insulin is not even lasting until bedtime, which is not my experience, sort of hard to believe. It could be that he's not getting a high enough dose, but he might want to try switching to Tresiba. The Tresiba certainly will last from morning till bedtime, and then he takes another dose of Tresiba at bedtime. Don't go using rapid-acting insulin to chase high blood sugars caused by using the wrong insulin. Switch to Tresiba. Okay. Can I expect extreme muscular atrophy to reverse once I get my blood sugars consistently under control? And how long might that take? I do yoga-type exercise for an hour or two on most weekdays, but they barely have enough muscle to walk. Oh, I barely have enough muscle to walk, and it never increases. Well, you find out why you have muscle wasting. There are many diseases that can cause muscle wasting, and I believe that Cushing's syndrome is one of the more common diseases that can cause muscle wasting. That's too much cortisol. I think that you have to treat the disease that's causing the muscle wasting. You also should check your free T3, because low thyroid can cause muscle wasting. And of course, taking a statin drug can cause muscle wasting. The game plan should be to get to the cause. Doing exercise to treat an ailment that you don't know what it is probably is not going to be the answer. I have dawn phenomenon. I take metformin, extended release 2,000 at bedtime, 2,000 milligrams. Would it work better if taken with food earlier in the evening? My guess is probably not. Probably you need insulin. That's my guess. But you could take, first of all, I wouldn't use metformin. Just switching to glucophage might make all the difference in the world, because we found that the generic metformins are relatively ineffective. So just switching to glucophage could do the trick. If that's not enough, you could try taking Avandia at bedtime. It comes in 3 sizes. You could start with a 2 milligram. If that's not enough, you go to 4, and then you go to 8. But the first step should be to take glucophage XR instead of the generic. Does the supplement glucosamine affect blood sugars? I've read that it does. I don't have any first-hand experience with my patients. I've had patients who took it and did not complain. I guess it may depend upon the dose, but I have read that it can raise blood sugar. Next person has non-alcoholic fatty liver disease, which is commonly caused by high blood sugars. In fact, I had it when I was a kid. I could feel my liver bulging below my ribs, and when I touched it, it hurt. And this existed until about 6 months after I learned how to normalize my blood sugars, which was many years later. I watch my carbohydrate intake carefully, but I find I have elevated morning glucose up to 115 even after 9 hours of fasting. Why is that, and what should I do about it? Well, this person has diabetes. Fasting now. The definition of diabetes, however, is a blood sugar of 126 fasting. And I don't buy that. I think that if you're waking up over 100, you should be treated as if you have diabetes, even though the ADA doesn't call it diabetes. So that's basically it. You should not only be on low-carb diet, you should be losing weight, you should be exercising, you should be taking whatever medications we recommend in my book, Diabetes Solution, if all the above doesn't do the trick to keep your blood sugars normal around the clock. Type 2 on low carb, not overweight, A1C of 5.3%, and have been dealing with severe dry eyes for almost a year, and have been taking Restasis, which is cyclosporin, for almost a year. I have seen 3 different ophthalmologists and am still struggling with eye pain from dryness that sometimes even wakes me up at night. Fish oil of no help. Thyroid normal. Do you have any insights or suggestions? Well, I didn't know that they were using cyclosporin to treat dry eye. That's news to me. There's a simple product called liquid tears, which is commonly used to treat dry eye, and some people have to use it frequently, like every hour. Other people may only need it once or twice a day. So that's certainly an option. Now, you say that your thyroid is normal, but normal thyroid, according to most doctors, does not involve checking the free T3. And the free T3 should be in the middle of the normal range, right smack in the middle. So you might want to get that checked. Another possibility is having a host of diseases that the eye doctors might not be familiar with, like scleroderma. So you might have to see another kind of doctor to see what other disease you have that's causing this. How can I reverse, then someone asked the same question about non-alcoholic fatty liver disease. Cross that one out. You have to control your blood sugars and lose weight. My flexor tendon on the bottom of my foot is swollen into a 2-inch cylinder, very tight, snaps when palpated, and extremely painful. Had CT scan, but specialists are unable to diagnose what's going on. And he says, glycation, ? Could be. Poor sugar control up until 1 year ago. Can a dislocated toe cause diabetic ulcer? Well, that's another question. I'm not going to talk about it. But this person has a swollen tendon on the bottom of his foot. And to me, that smells like Dupuytren's contracture of the hand. In Dupuytren's contracture, the tendons on the palm of the hand, which are usually invisible, can become this thick and painful, and even so tight that your hand turns into a claw. So if this person has had high blood sugars for a long time, he indeed could have a glycated flexor tendon, and the treatment would be, there are two treatments, one that I invented. The original treatment would be to inject it with collagenase. Collagen is probably the longest lasting connective tissue protein in the body. It's in tendons and other structures throughout the body. And in a healthy, young, non-diabetic, lasts 15 years, so its turnover is very slow. And if you glycate collagen, it gets stiff and swells and can cause frozen shoulder, Dupuytren's contracture, etc. So if you have glycated collagen, you do what they do for Dupuytren's contractures. There are specialists who inject collagenase into the Dupuytren's contracture. Collagenase dissolves, it's an enzyme, it dissolves collagen. The injection is painful. Usually, depending upon the size of the tendon, how big it's swollen, you may need multiple injections over a period of weeks. Now, that could be done to this structure, if that's what it is, but I invented a solution that is less traumatic and is good to experiment with, and that is a mixture of DMSO and collagenase. Compounding chemists can make it for you. I would use I used about 1 part collagenase to 6 parts of 99% DMSO. DMSO is a solvent that's almost as universal as water. The universal solvent is water. The second in line is DMSO, which is better than water in many respects because it also dissolves lipids, which water won't do. So a mixture of 1 part 99% DMSO with, 6 parts 99% DMSO with 1 part collagenase. And compounding chemists can get collagenase, but it requires a doctor's prescription. And what you do is you have the chemist put it in a roller bottle. I don't have a roller bottle handy, but you know what those are, for the kind they use for deodorants and whatnot. But a small roller bottle. You don't want to put up a lot at one time because it's so expensive, and if you spill it or drop it, you've lost gold. So you then roll this on the tendon. Another option is to put it in a bottle with a little brush, applicator brush, and you brush it on the tendon, and you do it, let's say, once or twice a day for a month, and see if it gets smaller. Now, you should do something to measure it initially so you have a guideline. So you might want to have someone take a photograph of it next to a ruler, a small plastic ruler, or you might want to have someone trace it so that you can compare its size down the road. I hope this works. Let us know if it does work. I've used this on one patient with outstanding results. Let's see what else we got. I have seen your seminars on hypothyroidism and free T3 and free T4, that TSH is not usually a good marker for disease management. I've heard great things about natural desiccated thyroid to treat this. Your thoughts on using this drug, which I did mention in my video. The original product was called Armor Thyroid. I believe it was originally made from rabbits. I think they make it now from pigs. And there are a number of problems with this. It comes in a limited number of sizes, whereas if you're getting slow release T3 compounded, you get an infinite number of sizes. You can get whatever the perfect strength is that you need. So that's one problem. Another problem is that it's a mixture of T4 and T3, and it has an amount of T3 that's way out of proportion to what humans make relative to T4. So the combination is rarely correct for humans. And perhaps the one remaining problem is that it's not time release. Although they sell it to give it for you to take once a day, it wears off in 8+ hours. Its half-life is 8 hours. So it's not covering the whole day. It's not giving you the full benefit of the T3. So there's no doubt that this is not my preference at all. It may be okay in an emergency if a patient has end-stage thyroid disease where they're sleeping all day and literally dying, and you want to give them something that works fast. Well, you don't even have to give them the Armor Thyroid. You could give them Cytomel, and you give that 3 times a day, and that'll pull them out of the stupor. But the Armor will also pull them out of the stupor because it's rapid-acting T3. But I don't recommend it at all. Let's see what else. How do you handle the need for specific timing plus limited food choices when eating with others? The excellent results trumps all, but I am having trouble socially and psychologically. Well, when I first started measuring my blood sugars, I was a bit chicken. In fact, I was the only one in the world who was measuring blood sugars, so I had a right to be. If someone saw me sticking my finger, they would probably think I was crazy. But it's a matter of priorities. I initially didn't bring up the subject when I ate at people's homes, but I had one emergency. We were eating at the home of a friend of my wife, and I asked her when she's going to serve dinner, and she said in 20 minutes, and it turned out to be 3 hours. And I got pretty bad hypoglycemia. I had my big meter with me at the time. You could see it on one of my videos. And my blood sugar had gone down to something like 50, and I start eating glucose, and I had to, when dinner was finally served, take insulin for dinner a second time. Since that time, I never believe what people will tell me about when meal is going to be served. I inject when I see the food. So that's what you're going to have to do. And we go into that in my book. Now, the business of eating what other people eat because you're embarrassed not to eat that stuff, that's your problem. Maybe you've had some kind of trauma that makes you anxious. You might try investigating treatment with EMDR, which might relieve the anxiety. EMDR is spelled E-M-D, like in dog, R. It's on the internet. There are therapists all over the world that specialize in this. In fact, my daughter, who's a clinical psychologist, is learning it right now because of it's of such great value. So I'd suggest you look into EMDR and you keep thinking, what's the proper priority? Really, your health is the proper priority. In my experience, people are interested and want to be helpful. They don't make fun of me. The only time anyone ever made fun of me for being careful about what I ate was a type 1 diabetic who was about 10 years younger than me, who was the wife of a friend of mine. And she actually became president of a lay diabetes association. And she told me when she saw me sticking my finger and ordering low-carb foods, "You're a professional diabetic. I'd rather be dead." And I said, "You will be, but it'll be slow and agonizing. You'll have a lot of pain." And she ended up having a necrobiosis, ulcers on her legs, having a toe amputated, being on dialysis, and she died, I guess, about 25 years ago. So she was 10 years younger than me, and she died 25 years ago, and she went through agony. And she was the only person who ever made fun of me for taking care of my diabetes while I was eating. Well, that's it for tonight. Thanks for listening. Our next session is going to be on Wednesday, September 28th. Please take a look at Dr. Bernstein's Diabetes University. We have more videos coming almost every week, and they should be of big value. So thanks for listening.